Welcome to part 1 of our series covering AMSER's 22 Don't Miss Lesions for radiological interpretation. Listed on this slide are the 22 lesions identified by AMSER as some of the most important radiographic findings for all physicians to know, whether they practice radiology or not. If these lesions are caught and appropriately addressed, potentially catastrophic complications can be avoided. And while this is not a comprehensive guide, my hope is that by watching this, you will be more prepared to catch these findings wherever you find yourself, whether that's in the hospital or the clinic. First on this list is honestly one of my favorites, the pneumothorax. If you remember from your preclinical years, a pneumothorax is simply a collapsed lung. And there are multiple ways to get to this collapsed lung. It can be from a rupture in the lung tissue itself, such as in a spontaneous pneumothorax's rupturing of a so-called bleb or cyst, or in an iatrogenic subpleural alveolus rupture in the case of ventilators that are set too aggressively. These can lead to a closed pneumothorax, which traps air in the pleural space as the chest wall moves outward and creates suction. Memorably, trauma to the parietal pleura can also result in air trapped in the pleural space. This trauma can be from an accident or assault, or it can be iatrogenic when trying to place a line, for example. When the hole creates a one-way valve causing air to increasingly build up in the pleural space, it's called a tension pneumothorax. Otherwise, it would be an open pneumothorax with the lung collapsing due to a lack of negative pressure holding it open instead of air in the pleural space pushing against it, as you would see in the tension pneumothorax. Of all of these, the tension pneumothorax is the most immediately concerning, as the volume of air in the pleural space can push against the mediastinum and contralateral lung, preventing both appropriate oxygenation and decreasing the return of blood to the heart. This is a chest x-ray of a female patient with a pneumothorax. Initially, when you're first starting to look for these can be somewhat challenging to find. But when you know what to look for, and you've seen a couple of them, they not only become simpler, but they become fun to look out for. Just to orient ourselves, this is the cardiac silhouette, and we can see posterior ribs as well as anterior ribs. This is the left lung, and this is the right lung. Looking at this left lung, we can see these faint lines that extend from the central portion of the lung all the way out to the periphery. Simply enough, these are known as lung markings. And these lung markings are within the lung tissue itself. Then they'll extend all the way to the visceral pleura, which is that outside edge of the lung. Typically, the visceral pleura is only separated from the parietal pleura by a thin layer of lubricating fluid. So when it's a normal chest x-ray, these lung markings should extend all the way to the chest wall. On this side of the patient, the right side, we can see a difference. Usually you'll look left and right and left and right, and you go back and forth. Up here, it doesn't match the same color that we see up here. It's darker. Not only is it darker, but it seems to lack those lung markings. And if we really look closely, we can see this crisp line that we'll zoom into a little bit later to show more clearly. But all of these lung markings in the right lung don't cross that crisp line. And that's really what you're looking for with a pneumothorax. If the lung markings denote that what you're looking at is lung tissue, and the definition of a pneumothorax is air surrounding that lung tissue, air within that pleural cavity that should just be a very thin layer of fluid, then that's how you denote between the two. That thin layer with the edge of the lung with no lung markings crossing it. Now, it's important to note that this is primarily true for an erect chest x-ray. If the patient weren't seated but were laying supine, then the air, instead of accumulating up in the apex, would accumulate in the anterior chest. And what that can often look like are these costophrenic angles on both sides. Can have deep sulci when the patient is laying on their back. In this case, however, and in most cases I've seen, what you're really looking for is in that erect chest x-ray, a crisp line denoting the edge of the lung that you can tell is the edge of the lung because these lung markings extend all the way to that edge but are not found anywhere on the other side of that very thin line. One thing that can sometimes trip people up is this kind of situation. We see this crisp line and someone could say, aha, pneumothorax. You see this is darker than this, bam. But no, that would actually be wrong. If you look, this, even though it's a crisp line, it is not a thin line. This is a very thick region here of a more dense tissue. And what we're actually seeing here is a skin fold that winds up having this very crisp edge. Sometimes it's because of wrinkly skin, perhaps in an elderly patient or perhaps in someone who has lost a lot of weight. Other times it might be the skin folds in an obese patient, and very frequently it can simply be because something was shoved up underneath the patient, perhaps the cartridge itself, and that can wind up causing a crease in the skin that can register in this way. The way that you would be able to tell that this is not a pneumothorax is, one, again, it's a thick line instead of a thin line, but then two, you can still see lung markings, especially right here. It goes past the line. You can see more lung markings right there going past the line. You will never have lung markings going past the edge of what the lung is. So this is not a pneumothorax. You can also diagnose pneumothorax with ultrasound, such as an EFAST, and CT. And CT is really the gold standard, and you can see why. This is a lung window view of an axial CT slice, and you can plainly see the pneumothorax in it. This here on this side is normal lung tissue, and like we see all of this, these lung markings going all the way to the edge of the chest wall. On this side, however, we see this enormous black spot where we do not have lung markings, and we see this denser area where honestly the lung has just collapsed in on itself, creating much more dense tissue in these areas. This is the pneumothorax. Now, it's not always going to be this big. Sometimes you see a thin pneumothorax, but it is much easier to see on this kind of image. This is the ultrasound view of the lung. It's done often in EFAST, and it can be challenging at first to know what you're looking for with a pneumothorax, but once you know what you're looking for, it's actually quite simple. On the left here is a normal lung ultrasound. On the right is one with a pneumothorax. Just to orient ourselves, we have the layer of skin, the same on this side, various soft tissue, including muscle, and then right here with the shiny top and the dark inside with shadow behind it, these are ribs, and you see the same on this side with rib shadowing as well. This bright line is the pleural line, so the parietal pleura would be right there. On the normal ultrasound, you can see in that pleural line movement that's happening, and you can see that kind of translating down in these areas beneath it as well. And that's because that visceral pleura is rubbing against or rubbing very close to that parietal pleura on the outside of the inside of the chest wall. On the right image here, there is no such movement. You can see a little bit of movement down here, but if you pay close attention, this is just a mirror of what's above that pleural line. And that's really because this is just static. When the ultrasound signal comes down and hits this big pocket of air, the signal scatters. And what you wind up getting, instead of anything being reflected back, is just this mirroring phenomenon. But this line is the main thing you're looking for. There is no movement in the pleural line. Now, it's important to note that this lack of movement, this lack of lung sliding is what this is called, does not allow us to say, aha, this is definitely a pneumothorax. We can't do that. This lung sliding will tell us it's 99 to 100% negative predictive value for a pneumothorax. If we see the lung sliding, then we can say, no, it's ruled out, it is not a pneumothorax. But if there is a lack of lung sliding, this could be due to other causes, perhaps due to scarring, or maybe a big bleb on the surface of the lung that isn't quite sliding. So we have to look for something else in our ultrasound in order to be able to get a better positive predictive value. And I'll show you what that is. It actually gets us up to 100% positive predictive value. To understand what it is that I'm going to tell you about, we really have to go back to the CT so that we can get a 3D idea of what's going on. If I shoot ultrasound signal down this way, then because this is healthy lung, I'm going to get a lung slide across this line. If I shoot that ultrasound signal down this way, I'm going to get that second image, the one that was on the right, where there's no movement along the bottom beneath that pleural line. I'll get the same image here. I'll get the same image here. Depending on the depth, I'll get the same image here. But then when I go right about right here, I'll start to get a different image. This is where the air of the pneumothorax and the connected part of the lung to the chest wall show up between two ribs. And this is called the lung point. And I'll show you what it looks like on ultrasound. You can see here that when you're looking at this left side of the image, you have that lung sliding that we're talking about, and you can see how it's doing the same in the static below as well. You can see it all moving. But if you were to hold your hand up and cover this part and just look at the right, there's no sliding in the pleural line. There is no real movement that isn't just a reflection of the muscle tissue exterior to that pleural line down here. And that is what we call the lung point sign. This is 100% positive predictive value for a pneumothorax if you're able to find the point that this appears. Now, it's important to note that you won't always find this. If it's a complete pneumothorax, then you essentially have the whole lung shriveled up like a raisin, dead center in that chest wall, whether it's the left or the right chest. And because none of the lung is going to be touching the parietal surface of the chest wall, you won't find a lung point anywhere in that scan. But that is more the exception than the rule. If you find this lung point sign, then you can say this is a pneumothorax. Next is Pneumomediastinum. Now, Pneumomediastinum is similar to the pneumothorax, except that in the pneumothorax, the air is trapped within the pleural cavity. This is an image from the Cleveland Clinic, and that pleural cavity is lined by that blue dotted line. Anything within the pleural cavity, if it's air trapped in there, will be a pneumothorax. On the other hand, if it's within this yellow dashed line, this is the mediastinum, and it will wind up being a pneumomediastinum in that situation. Now, you can also have air trapping within the heart. We're not going to cover that in this list, but that would be a pneumopericardium. And just to point out that these things are different, you can have all three of these in the same patient: a pneumopericardium, pneumomediastinum, and pneumothorax, all at the same time. Now, talking specifically about the pneumomediastinum, there are largely two ways to get this. One is by the rupture of a bleb again, just like with the pneumothorax. The difference, however, would be that the ruptured bleb would be located so that the released air would follow the parabronchial or paravascular sheaths and enter the mediastinum that way. This would be primary pneumomediastinum. Secondary pneumomediastinum would be then from some kind of secondary cause, often blunt or penetrating injuries to the chest or abdomen or the structures contained therein. Most notably, you hear about this with things like Borhave syndrome or from trauma from iatrogenic causes. So, how do we diagnose pneumomediastinum on chest x-ray? These findings can sometimes be pretty subtle, especially some that I'm going to show you a little bit later. But essentially what we're looking for is evidence of air trapped within the mediastinum, air trapped around the heart and the great vessels and that kind of thing. And you can see that here. This is the shadow of the heart on the chest x-ray. And there is this area of lucency that is surrounding the heart with a more dense structure external to that. That's air trapped in the mediastinum surrounding the heart. And that's how we diagnose it. And that air doesn't only have to go along the side of the heart, but can also be along the inferior aspect of the heart, as well as in this pediatric image. This is called the continuous diaphragm sign, and can be, if it's above the diaphragm, it is indicative of pneumomediastinum. The other thing that we look for on chest x-rays is signs of streaking, and the black arrows in this image point to that streaking. You can see it right here, and we really shouldn't be seeing this. This should tip us off whenever we notice this pretty subtle sign that pneumomediastinum has to be considered. Additionally, these red arrows are pointing to areas of lucency that are pockets of air within the soft tissue. This is also called subcutaneous emphysema, and it demonstrates that there is either maybe there's surgery done in the area, or it could be that there was a rupture in either the esophagus or some other structure that has allowed air to get trapped within the soft tissue layers. Now, as is true with many things, CT can make the diagnosis of pneumomediastinum significantly easier. This is an axial slice of a chest CT. You can see the beginning of the diaphragm here, so we're fairly low in the chest. And this black band that wraps around the heart is the air that is described in pneumomediastinum. This is trapped within the area of the mediastinum surrounding the heart. And if you look in this coronal view, that same air trapping is going around a significant portion of the heart. And if we were to scroll through this stack, you would be able to see that it actually travels up into the neck as well. CT, because of our ability to view it in 3 dimensions, just makes this a lot easier to be able to catch those subtle findings than is the case when you have the layers upon layers in chest x-ray that can sometimes cloud the image. Next up is Pneumoperitoneum. Now, pneumoperitoneum is essentially air trapped within the abdominal cavity. And there are a lot of ways that this can come about, most commonly due to perforated bowel or even iatrogenic causes, like the patient recently undergoing laparoscopic surgery. But really, this can happen anytime there is a weakness in part of the GI tract, leading to air escaping from the lumen and into the abdominal cavity. This can be from things like peptic ulcers, cancer, blunt or penetrating trauma to the abdominal wall, or even to the lumen as well. It could be from necrotizing enterocolitis or even ruptured diverticulum. On an erect chest x-ray, you can see pneumoperitoneum as air trapped beneath the diaphragm. In this particular chest x-ray, the air is trapped on both sides, but that won't always be the case. Sometimes you'll just see it on one side or the other. Now, it's important to discuss at this point how we distinguish this from the pneumomediastinum or pneumopericardium that we've already discussed. And it's actually quite simple. Here you can see the air beneath the diaphragm. The mediastinum only goes down to the diaphragm itself. So if the air that you're seeing is underneath the diaphragm, then it is not pneumomediastinum. That continuous diaphragm sign is not talking about this, but is talking about when you can actually see air above the diaphragm and below the heart. Now, in addition to this often having a small amount of air, which can make this a subtle sign at times, there are also a couple of things that you need to be aware of that might trick you if you aren't aware of them. First is what's called Chilaiditi's sign, which is the radiological sign that comes from colonic interposition, usually above the liver. This can make it look like there's an abundance of free air, but if you were to CT this, you would find that the air is safely within the lumen of the colon. And how can you tell that this is colonic interposition instead of free air? By seeing the haustra here. You can see each line for the haustra of the colon, and that lets you know that this isn't just free air beneath the diaphragm, but this colon is actually pressed up against the diaphragm. It's way above where it would typically be found. This can happen in something like 10 to 15% of patients and is often asymptomatic. The second thing is when you're dealing with a supine patient. If the patient isn't seated erectly, then the air won't accumulate in the superior regions of the abdominal cavity. In this case, looking for Wriggler sign can be helpful. This sign is when there is air on both sides of the bowel wall, and you can see that here and here. The green arrows point to the inside of the bowel wall, and the white arrows point to the outside of the bowel wall. Now, sometimes you do have to be careful with this because sometimes two bowel loops can press together and make it appear like you're seeing the inside and outside of the bowel wall. But when that isn't the case, then this is Wriggler sign, and you know that the outside is free air, which is causing that difference in density, which is picked up on chest x-ray, and tells you that this is the diagnosis that you need to consider. Now, as I've said with the previous diagnoses, CT makes it much easier to spot free air, and Pneumoperitoneum is no exception to that. In this axial CT, you can see plainly these black areas here, these radiolucent areas where air has escaped, likely from a perforated bowel, and has accumulated anterior to the liver. And on this sagittal cut, you can see it here too. Remember that this patient, even though it looks like he's standing up, is actually laying down, so the air is going to move anteriorly in the body, and you can see that on both of these here. Now, the other benefit to using CT for pneumoperitoneum is that it's much easier to not only find the pneumoperitoneum itself, but to find the cause as well. Number 4 is pleural effusion. A pleural effusion is when fluid builds up in the pleural space between the visceral pleura of the lung and the parietal pleura of the hemithorax. Now, there's a whole slew of reasons why this can happen, which is all beyond the scope of this video. But the clinician can use Light's criteria to nearly cut the differential in half. I like to think of it as there is extra protein in LDH in exudative effusions. And when that isn't the case, when pleural protein in LDH is lower than 0.5 and 0.6 respectively, we're looking at a transudative effusion. Knowing this can help us to identify what else we might want to be on the lookout for, and you can see some of the main causes here. But before we know these lab values, we first have to be able to identify the pleural effusion on imaging. So how is it that we do that? Well, for one, sometimes the chest x-ray itself can make the presence of a problem obvious, like in this film here. Other times, however, the effusion can be much subtler, like in the case of a PA or frontal radiograph, given that it takes a minimum of 200 to 250 milliliters of fluid for an effusion to be visible on this kind of imaging. In the context of a low volume effusion, you may only see a meniscus at the costophrenic angle in a frontal film, and in a supine patient, you may only see a diffuse haze throughout the lung field. Now, the way to get around this is to either take a erect lateral film where you can see the blunting of that posterior aspect of the costophrenic angle, or to take a lateral decubitus film with the side the patient is laying on being the side that's affected. When that happens, the fluid is able to escape that posterior aspect here and accumulate in the pleural space on the side that is dependent to gravity. But for these larger effusions, the fluid will be much denser than the lung tissue itself, and in the absence of concurrent pneumothorax, will also demonstrate a meniscus. Now I'm going to breeze through this because this isn't our focus today, but an important complication of pleural effusion is empyema. And some of the ways that you can distinguish between the two are as follows. Looking at the chest x-ray, for one, pleural effusions tend to be bilateral, while empyema tends to be unilateral. Also, with the pleural effusion, as we discussed, you tend to see that meniscus shape, and with empyema, you have more of an obtuse angle with the chest wall. On CT, you would tend to see a crescentic shape with pleural effusion, but with empyema, you have these convexities where there is a buildup of pus pushing against the lung. Next, pulmonary edema. Pulmonary edema is a fluid collection in initially the interstitial space or later the alveolar space of the lung, which can, unfortunately, ultimately interfere with the lung's ability to diffuse oxygen and carbon dioxide in and out of the blood. Pulmonary edema is divided into two etiological categories, cardiogenic and non-cardiogenic, labeled B and C on this diagram respectively. Cardiogenic pulmonary edema is fluid buildup that results from increased hydrostatic pressure within the capillaries surrounding the alveoli. This is most frequently due to a backup of blood from left ventricular dysfunction, left heart valvular dysfunction, or certain arrhythmias. The increase in hydrostatic pressure overcomes the interstitium's oncotic pressure, resulting first in interstitial pulmonary edema and later to airspace opacification. In non-cardiogenic pulmonary edema, fluid travels through the interstitium and into the alveolar airspace due to an increase in permeability in the alveolar capillaries, which also contributes to an increased protein presence in that fluid. This can be due to a number of things, including pneumonia, inhalation injury, sepsis, airway obstruction, or many other possible causes. This slide is a reminder that there are chronological stages to pulmonary edema that logically follow the pathophysiology we just talked about. Severity level 0 is no edema. This is simply a normal chest x-ray. Level 1 is still not considered edema. This is simply when the blood is beginning to back up, but no or an insignificant amount of fluid has leaked into the extravascular space. Level 2 is when we can first accurately refer to this as true pulmonary edema, and it's when the fluid leaks into the interstitium, causing this appearance that reminds me of exaggerated lung lines. Finally, level 3 is when the fluid invades the alveolar airspace itself, ultimately causing an appearance on chest x-ray of the lung spaces being filled with cotton balls. When it reaches this level, it can be very hard to distinguish pulmonary edema from other processes like hemorrhage or infection, and the main things that may help are that edema is often symmetrical and clears up quickly. This is a patient with pulmonary edema, but which type? We can look at a few things to develop a suspicion towards one or the other. One of the striking features of this image is the centralization of the edema. In non-cardiogenic pulmonary edema, the opacities are diffuse and patchy throughout the lung fields, but in cardiogenic pulmonary edema, the opacification is more central or perihilar. This is sometimes described as a bat wing sign, from the edges looking like the edges of a bat's wings. Cardiogenic pulmonary edema can also show a subtle finding called curly bee lines, which can be seen at the periphery of this image. These are interlobular septa caused by pulmonary edema in the lymphatic channels of the lung. Parabronchial cuffing can also be noted as fluid builds up in the interstitium. Pulmonary edema can also be seen outside the curly B lines, here in the form of blunting of the claustrophenic angles. Probably the biggest tip-off, though, of a cardiac etiology is cardiomegaly, an enlarged heart. This particular image is of a patient in her third trimester presenting with peripartum cardiomyopathy, a clinical sign of which you can't afford to miss being pink frothy sputum. Just to contrast this image with the other type, this is non-cardiogenic pulmonary edema, and we can see here that patchy, diffuse, almost cotton ball appearance of the edema throughout the lung fields, as well as air bronchograms. That concludes part 1 of our series on AMSER's 22 Don't Miss Lesions. We will continue with aortic dissection in part 2.